So diagnosis, a thorough history and physical examination focusing on the head and neck are performed. The location and extent or the size of primary tumor and clinically positive lymph nodes are documented. Imaging follows and should include at minimum contrast enhanced CT from the skull base to the mediastinum. MRI is used in cases where dental artifacts obscure tumor view on CT. The extent of marrow space invasion that must be determined. Perineural spread or skull base invasion is suspected, or with sinonasal, nasopharynx and salivary gland cancer. In the setting of carcinoma of unknown primary with regional lymph node involvement, a positron emission tomography PET CT scan may be performed to identify a potential primary tumor prior to any intervention. Perhaps the greatest utility of a PET CT for head and neck cancer is the detection of distant metastasis, for which the sensitivity and specificity are 92% and 93% respectively. However, false positive rate for detecting nodal metastasis on PET CT scan can be up to 73%. The most common incidental finding include benign parotid masses, that is Warthin's tumor or oncocytoma, adrenal adenoma, and inflammatory mediastinal nodes. The pre-treatment scan should be obtained prior to the biopsy so that biopsy related changes including resulting reactive regional lymph nodes, they are not confused with the tumor. PET CT scan is preferred to evaluate for distant disease in patients with loco-regionally advanced cancer like T3, T4 primary or N1 nodal staging. Patients with N3 neck disease as well as those with N2 disease with nodes below the level of thyroid notch have a 20 to 30% risk of developing distant metastasis. And if a PET CT is not performed, a chest CT is obtained to determine the presence of distant metastasis and or a synchronous primary lung cancer. Brain imaging is not routinely performed in the staging of squamous cell carcinoma. In most cases, a biopsy of primary lesion can be performed under local anesthesia in clinic. However, most laryngeal, hypopharyngeal and base of tongue lesions, they will require direct laryngoscopy under anesthesia. Given the risk of synchronous cancer, that is 1 to 10%, some advocate routine triple pan endoscopy, that is laryngoscopy or pharyngoscopy, nasopharyngoscopy, bronchoscopy, and esophagoscopy. Pan endoscopy is a low morbidity procedure that can provide information useful for treatment planning, particularly when the primary site is unclear, when there are diffuse mucosal abnormalities, and when there is evidence of low neck disease. Otherwise, the yield can be low. An alternative to a biopsy of the primary lesion is to obtain a fine needle aspirate biopsy of a clinically suspicious neck node on the ipsilateral side of visible primary tumor. An excision biopsy of the node is not routinely performed unless lymphoma is suspected or FNA results are equivocal. If squamous cell carcinoma is consideration, the excision should be done in a manner to facilitate subsequent management, including neck dissection. Occasionally, the diagnosis may be made by clinical and radiographic evaluation when a biopsy should be avoided in situation where the treatment is definitive for RT and where obtaining a tissue sample is risky, like in paraganglioma or juvenile nasopharyngeal angiofibromas. Head and neck surgeons, radiation oncologists, medical oncologists, diagnostic radiologists, reconstructive surgeons, pathologists, dentists, speech and swallowing therapists, physical therapists, and social workers may all play a role in treatment planning at a multidisciplinary tumor board.